Tanisha from Blackwood's Healthcare Learning Center, and today I wanted to share with you one of the nursing skills that is being offered at Blackwood's Healthcare to help nurses be prepared for the world of work and any level of nurse, whether you're a student nurse or a registered nurse, could be an international educated nurse who just wants to get their skill set a little bit more polished. It could be that you're a family member who is now providing care for your loved one, and part of that is for you to pass a Foley catheter on them, whether intermittently or maybe they have an indwelling catheter and you need a little bit of help with knowing how to manage and to care for it. So this is what this video is about. I hope you do enjoy. I hope you find something in there that may be able to help you in your day-to-day. All right, so firstly, a patient may need a Foley catheter for any number of reasons. It could be for a procedure, maybe they're post-surgery. It could be that they have a bladder dysfunction where they're not emptying properly, or they're emptying too frequently. They have incontinence of any level. In addition to that, it could be that the patient is being monitored and we just want to know how much urine is being passed, and it's usually a good guide for fluid balance in healthcare setting of taking care of a patient. And so any number of those reasons could warrant a patient having a Foley catheter. A Foley catheter is usually a rubber or latex made device that is inserted into the bladder, whether it be a male or female, to relieve the urine or to rest the bladder for healing or whatever the reasons are. In addition to that, there are risks involved with putting in a Foley catheter. And the most common is a bladder infection, because you are administering something that is foreign to the body. And so putting a Foley catheter is usually done under sterile conditions. However, in some instances, especially in a community where sterile gloves and the whole sterile apparatus is not necessarily readily available to the patients that are being cared for in the community, there are not really accepted, but good practice also is, if you don't have sterile procedures available, make it as clean as possible for inserting a Foley catheter. And this is true especially in patients who are on long-term, maybe in and out Foley catheter, or they are permanently needing some sort of a drainage of urine at some point in their life. Okay, that's for the main risk, infection. There can also be injury to the urethra, and this can cause a lot of bleeding. So whenever we are advancing a Foley catheter in a patient, we really don't want to be going against resistance. If you're inserting a Foley catheter and it is there's resistance with you advancing that catheter, my suggestion is to maybe back off, reposition. Maybe we need to have the doctor come in and assess the patient, because there may be some stricture of some sort, and you forcing the catheter to advance is going to cause some trauma. Especially for a patient who is on blood thinners. Once that trauma has occurred, it is based on how the tissue are in terms of being soft tissue and so on, it's going to bleed and bleed considerably. Right, so if you find any kind of resistance, I'd say back off. Because of the high risk of injury and infection, we want to make sure that we get the patient's consent. We want to talk to them about what the risks are and the benefits as well, because if they're having some sort of incontinence or they have a procedure to be done, and Foley catheter is indicated, then we have a conversation with them to say, this is what we would like to do, this is what the plan is, these are the risks, and if they are in agreement, then and only then do we go ahead with that, because they may very well say that this is not something that they want to do. Hello again. Now, with any catheter tray, the setup is always going to be different. There's some brands, some companies, when they package it, they package everything that you need within that container. So you have your gloves, you have your catheter, you have your drapes, and so on. However, as in a lot of the cases, the things are individually packaged, and you have to prepare it on your sterile feel. So for example, this is a Foley catheter of 14 French. This one is a silicone elastomer coated latex Foley catheter, and it's by Medline. And if we turn it over, we see it inside of the package. And with these Foley catheters, there's an external packaging and then there's an internal package. At the tip of the catheter, there are usually openings that would facilitate the urine draining. Now back to the setup. Now in this setup, I have some drapes, and you'll get two types. The one here has a shiny underside and then a not so shiny inner side, and the shiny side always goes on the patient's bed when we lay it down. We have another drape that would cover everything except the area that we want to put the Foley catheter in. Also, we need our sterile glove, and in some of the trays they come with one size type of a glove. For me, those are too small, so I usually take a separate sterile glove and place in the tray. All right, so just see what your comfort level is. If the glove that comes with the setup is okay with you, use it. If you need to, then take the size that matches your hands well. Also, I have some betadine solution, a syringe. I have two types of catheters here. I have the Foley catheter, which would have the option to inflate a bulb to leave it in place. And I also have a catheter that I'll use for in and out. Okay, that one does not have the same makeup so much as the indwelling one. Also, you need a drainage bag, because this is what you're going to connect to the catheter itself to facilitate the drainage of the urine. Sterile gloving is a part of any aseptic procedure that we'll do for a patient that requires us to care for them with minimal transference of microorganisms. Each packet of sterile glove has an inner package with a pair of gloves, and you select the glove based on the size that is suitable for your hand. To open the packet, we want to just grab at the top here, and usually there's an indicating arrow, and we want to pry that open. So to open, we're just going to drop it in our area, and then we're going to bring it into focus so that we can see exactly what we need to do. So on the left side, there's a demarcation of a hand with an L indicating left side, and there's a demarcation of an R on the other hand, which is indicating right hand. And to open the package, we're just gonna get our fingers just underneath this middle portion. It's about an inch of area that we can touch on each border. Right, so we're just gonna grab the borders and we're gonna pull that package all the way out. And we're gonna make sure that it stays down so that we don't have any kind of contamination happening. Once we're satisfied, we're just gonna let it go. Then the first thing I'm going to do is to glove my dominant hand. And so to do that, I'm going to use my left hand to hold the cuffed area of the glove. And the cuffed area of the glove is this area that is folded upwards, right? This is the part that's going to end at your wrist, and it's folded upward for ease of access. Okay, so what I'm going to do is with my left hand, grab the cuff end of the right glove, and then I'm going to use my right hand in a shovel-like motion to get into the glove without touching the outer layer and without contaminating my other glove. Okay, so we do not let go of the cuff area until we're satisfied that the glove is in place and over our hand. And so we just want to pull that all the way up and then let it go. Okay, that's it. Do not interfere with here and try to fix it, because there's too much of a risk of you inadvertently touching the glove and then you have to redo it. Now the next step is to get the glove onto the left hand. And so what we want to do is to use the right hand, and we're going to now embedding it into the cuff, the inner part of the left cuff. Let's turn it around like that so you can see, right? So my fingers are within the inner part of this cuff. And so what I want to do at this point in the same shoveling movement is to guide my now bare left hand into the glove, and being careful not to get my right hand contaminated. So the entire time my fingers remain inside of the cuff, right, and protected away from my skin. When I'm comfortable, I let it go. Sometimes you're putting the glove on and one or two of the fingers might be in odd places and it doesn't quite fit right. Only when you're fully gloved do you touch and manipulate the glove to make it fit. These are a little bit big for my hand, but it's what I have available at this time. All right, so once we're gloved, the tendency now is to scratch somewhere, your face, or to touch something on the patient's environment. We are not to touch anything. Your hands are not to be placed below your waist. It's to be maintained in an upright position and only to be now focused on the task at hand, which is the procedure to be done. Once we're completed with our procedure and we need to deglove, there are many ways, but one safe way to deglove is to grab the inner portion of the glove of one of the hand. In my case, I'm using my dominant to my non-dominant, and you just want to pull that glove over your fingers so that the outer portion becomes now the inner portion, and you let that go. Okay, then with your non-dominant hand, you're going to grab the edge of the glove of your dominant hand and you're going to just pull that all the way over so it becomes one ball. Okay, and this all together you're going to discard inappropriate garbaging system, and you're going to now have proper hand washing done at this point. There are some who say to do, if you have hand sanitizing alcohol base available, that may be appropriate, but hand washing with soap and water is the best to be done at this point. All right, now please join again as we complete other procedures that sterile gloving may be a part of. Okay, so we begin. So I'm going to decide at this point which hand is going to be, for lack of a better term, my dirty hand, and which hand is going to be my clean hand. Now I'm right hand dominant, so my left hand is going to be my dirty hand. That's going to be the hand that's holding the labia and that's making this the way for me to do what I need to do with my sterile hand, which is my right hand. Okay, so I'm going to take my left hand like a U, and I'm going to put it just on top of where the labias are, and I'm going to push them apart. Okay, now with pushing them apart, it's going to bring to focus the vagina, and sometimes possible you're going to right away see the urethra. There are times though when it's not like that, and so you're now going to have to use landmarking. So again, find the clitoral hood, and then a few centimeters down is usually where I find the urethra. All right, so first thing I'm going to do is I'm just going to clean. So you're going to start with the outer parts and then the middle. Okay, so you're going to do a full, hold that apart, and a full wipe down, discard. Then we're going to do the other side, closest to you now, and then down. And then we want to go in the middle now, right where we think the urethra is, and wipe and throw that out. Okay, we're going to keep the hand on the spot. We're not going to let it go. We're going to get our catheter that's already set up. It's already lubricated. And we're going to tell the client now that the catheter is going in, to take a big breath in. Take a big breath, Miss Brown. And we're going to advance the catheter in. Now, once you begin to advance the catheter, if there's no resistance, as soon as you get to a point where you see the urine start to come back, I usually go in another inch or two, because I want to make sure that I'm not inflating my balloon right at the sphincter of the bladder. So I want to go in a little bit more. I'm still seeing urine flow. There's no blood, which is going to tell me if I caused some kind of a trauma, right? And then we want to inflate the balloon. This is a very important step, because if you insert the catheter and you never inflate the balloon, what's going to happen is that this Foley is just going to slide right out, right? And so you're going to end up have to do it again, and the patient is going to have to be traumatized all over again, or have to go through this procedure unnecessarily all over again. And so once you have gotten urine flashback, it means you're confident it's in the bladder, right? And then you want to go in a little bit further to make sure that you're past the bladder sphincter with the balloon, and then you want to inflate, and then you just check it. You just gently tug on it to make sure that you're in and it's not coming out. Okay, that's how you know you're in, when it's inflated properly, it's in place, and it's not coming out. All right, and so once you're done that, no longer we need to be sterile, and so I'm just going to begin to clean up my area. At this point, I usually like to change my glove, because I would have had betadine on it. I would have had other bodily fluids on my hands. So at this point, I really do like to take these off, and I want to put on a regular glove to complete the cleanup process. Now, removing the catheter is not a sterile procedure, but in the event that the patient has completed the need for the catheter and it now comes time to remove it, what we want to do is we want to have, you can use gauze, you can use wet wipes, whatever you have available, and you want to have your handy syringe. And so for this Foley catheter, I had put 10 mils of sterile water in it. So my expectation is I'm going to withdraw 10 mils of sterile fluid from it. So I'm going to do that. Right. I'm going to remove my syringe from the catheter. And then I want to slowly, after I'm telling her, Miss Brown, I'm just going to take the catheter out. After 2, 1, 2, slowly I'm bringing that out. Catheter comes out. I want to just clean the perineal area, because later on I'm going to provide proper perineal care. And so I want to now throw the Foley and the Foley bag and measure the contents and throw that out as well. Now let's say that the patient is just getting an in and out catheter. This patient does not need an indwelling catheter. This patient is probably voiding on their own to some degree. However, they're having retention, and based on our bladder scan results, we need to assist this patient with emptying their bladder. So everything, all the steps that I show with the Foley catheter is going to be the same. You're going to be sterile. You're going to make sure that your perineal area is cleaned, and you have lubricated your catheter. Now the difference with this catheter from the one that I used before is that with the Foley or indwelling catheter, there is a part for the urine to drain, and then there's another area where you would inflate the tip of your Foley. Now this catheter does not have any sort of a balloon device. All right, so with the Foley catheter that's indwelling, when you inflate it, this is what the bulb will look like on the inside. Okay, so when we inflate it, that's what's going to happen. However, with the in and out catheter, there is no ballooning at the tip, only the openings to facilitate the drainage. Okay, so we've cleaned, we have lubricated our tip, and so again, the principles are the same. One hand on the labia to open that area to us, and with this one we do need to have a container for getting our urine in. Okay, so with the left hand on the labia, the right hand guiding the catheter into the urethra, just as we did before, we see urine flashback, and so we begin to allow the urine to drain, and we allow it to empty fully into our container, which we're going to measure to give us an accurate reading of the output so far. Once we're satisfied and there is no urine coming back anymore, you're going to now slowly remove this catheter to be thrown out, because with the in and outs we don't reuse them in the clinical setting. It may be different in the home setting or in the community, but in the clinical setting we don't reuse our in and out catheters. Okay, and again we remove our items that we have used for the insertion of the Foley, and we cover our patient, providing privacy. And we're talking to our patient to find out how they're feeling. Does the catheter feel very uncomfortable? Because as I said earlier, one of the common complaints, one of the common issues with a Foley catheter is that they have a great discomfort with it, right? And so sometimes we need to adjust the catheter a little bit to make sure that they're comfortable with it, and not there's no major discomfort being provided because of our Foley catheter. Now once we're done with catheterizing our patient, we need to document, and documenting is important, because if you didn't document it, you didn't do it, right? So we want to select a timestamp. So let's say we did it at 10:15 in the morning, right? So we want to say in our notes that Foley catheter inserted as per order for urine in and out monitoring of patient. We want to tell how the patient tolerated the procedure, what color was the urine drainage that came back in the catheter, because sometimes it may be bloody, sometimes it may be cloudy, sometimes there may be sediments in the urine. So you want to talk about the urine, how it looked. Did it have a smell? Because some urine may be malodorous, and so you want to talk about that as well. And then throughout the process of the remainder of the shift, you want to go back and see if there's urine actually draining from that catheter, right? And to inform the doctor or the most responsible physician what you're seeing, what you're observing, and just to be prepared to do the appropriate interventions as is needed. So that's it from us from Blackwood's Healthcare Learning Center. I hope you join us again when we present future nursing skills, and have a great day, and just know that you're amazing. God bless.